Welcome to this explainer. If you or someone you care about is looking at a skin cancer diagnosis, you're probably hearing a few surgical terms thrown around, particularly Mohs surgery and standard excision. Honestly, it can get pretty overwhelming. So our goal today is to help you navigate that exact decision. We're going to dive right into what the objective, evidence-based data actually says, cut through the confusion, and give you the tools to make a highly informed choice about your care.
Right off the bat, I want to mention that all the evidence we'll be discussing today is current as of July 11, 2026. And here is the direct answer up front. Both of these operations remove skin cancer. They are both highly validated. But the really crucial difference between them has nothing to do with the shape of the incision or what it looks like from the outside. The difference lies in exactly how and when they examine the surgical margins. You see, Mohs surgery maps the complete peripheral and deep margin during the surgery itself. Standard excision, on the other hand, uses representative vertical sections after the tissue is completely removed.
Okay, let's dive into this. We have a very straightforward roadmap for you. First, we'll break down that margin difference we just talked about. Then, we'll look at when mapped margins really matter, followed by when standard excision fits best. After that, we'll examine the actual clinical evidence, and finally, we'll cover reconstruction and your next steps.
So, Section 1. Let's really understand this margin difference.
As I mentioned, the biggest contrast here isn't what's happening on the surface of your skin. It's entirely about how the edge of the removed tissue is checked and when that vital information actually gets back to your surgeon. Mohs maps the complete peripheral and deep margin while you are literally still right there in the operating room. The tissue is processed horizontally so the surgeon can evaluate a fully mapped surface. Standard excision is different. With standard excision, the surgeon removes the visible tumor along with a planned room of normal-looking skin. That specimen then goes off to a lab, it's cut into representative vertical sections, and the results arrive days after your surgery is complete.
Moving on to Section 2. When do those mapped margins actually matter?
You might be wondering, when does having that real-time continuous map view give us the most value? Well, real-time mapped margin information matters most for recurrent tumors, where a prior treatment didn't quite get it all, or in high-risk tissue-sensitive areas. Think about areas like your nose, your eyelid, or your lip, where literally every single millimeter of tissue counts. It's also absolutely crucial for tumors with poorly defined borders or aggressive pathology. In those scenarios, getting that real-time feedback can fundamentally change the surgical plan.
Section 3. Let's talk about when standard excision is the right fit.
I want to be super clear here. Standard excision is not some inferior fallback option. Not at all. It is a highly appropriate, incredibly sound choice for the right type of skin cancer. Specifically, standard excision is a sound choice for a well-defined, lower-risk primary tumor in a location where a guideline-appropriate margin is safe. For example, if you have a well-defined lesion on your arm or trunk where removing a planned margin of tissue doesn't compromise critical anatomy, standard excision is highly efficient and totally appropriate.
All right, Section 4. Let's look at the clinical evidence.
Now, what's really interesting about this slide is getting into the actual clinical statistics behind the medical guidelines. In one randomized trial of recurrent facial basal cell carcinoma, 10-year recurrence was 3.9% after Mohs and 13.5% after standard excision. Now, we have to be very careful here. We absolutely cannot generalize this result to every basal cell carcinoma, every facial cancer, or every skin cancer. It specifically highlights the value of margin mapping in that particular high-risk scenario.
Let's broaden our view a bit. If we look at a 17-study pooled comparison, this is a massive meta-analysis of 6,503 keratinocyte cancers. The recurrence was 3.1% with micrographic surgery and 5.3% with conventional excision. That gives us a pooled relative risk of 0.48. So, this gives us a really substantial, evidence-based snapshot of how these recurrence rates compare on a larger scale.
And for very high-risk cutaneous squamous cell carcinoma, we look to a 12-site retrospective observational cohort. When looking across local recurrence, nodal metastasis, distant metastasis, and disease-specific death, we must strictly clarify that these outcomes were associated with the margin assessment method. Because this is an observational cohort, we do not narrate this as definitive proof that Mohs directly caused better survival, but it certainly reinforces the idea that as a tumor's risk profile goes up, having complete mapped margins becomes increasingly important.
Finally, Section 5. Reconstruction and next steps.
This is absolutely crucial to understand. Achieving margin clearance directly dictates how your surgeon plans the reconstruction. Step 1. Settle the cancer clearance strategy. Step 2. Plan the flap or graft repair. Basically, reconstruction planning strictly follows the cancer clearance strategy. The repair should not outrun the margin information, because if you move nearby tissue to close a wound before you know the margins are clear, a later re-excision becomes incredibly complicated.
Also, we definitely need to mention that surgery isn't the only path. Depending on the situation, ED&C, topical treatment, radiation, or even observation can perfectly fit selected tumors in patients. Observation, for instance, might be used for low-risk lesions if other health factors make treatment too burdensome. The key takeaway here is that Mohs is not necessary for every single cancer.
So, when you're sitting in the doctor's office and hearing all these medical labels, what should you do? Well, I want to leave you with one incredibly empowering question to ask your surgeon. Write this down. Ask how the margins will be evaluated and whether having that answer during surgery would change the plan. By shifting the focus away from the name of the procedure and onto the margin testing itself, you're going to be ready to make a highly informed, confident decision. Thanks so much for joining us for this explainer.